Welcome back to this first Virtual Digital Economy seminar for the fall. Actually, on the third official day on fall, so we're right on time. It's a great pleasure to see all of you back here and to start the schedule again with a stellar speaker. Our moderator for today will be Luis Aguiar at the University of Zurich. And so the format will be the same as in the spring. If you have any clarifying questions throughout the talk, please send these to Luis in the chat window. He'll unmute you so you can ask the question directly to Anjana. We will use the same channel to collect questions for the Q&A after the talk. And as always, the session will be recorded and we'll make it available on YouTube. So if you do ask a question and appear with your picture, then you will be in the recording. So without further ado, very happy to hand over to Luis, to the moderator.
Thank you, Hannes, and thank you everyone for joining us today. So today we have Anjana Susarla. She's a professor of information systems at Michigan State University. She has done extensive work on the economics of IS, social media analytics, and the economics of AI. So she's made some great contributions on the role and influence of social media and online user engagements in different settings. She has an outstanding publication record in the most prestigious IS journals. And if you work on social media or any of these topics, there's no doubt that you have come across several of her papers. So we are very honored and extremely happy to have her with us today. She will present her work. Go to YouTube and call me in the morning. Well, don't do that now, but that's the title of the paper. Use of social media for chronic conditions. So Anjana, thanks for being with us today, and the floor is yours.
Thank you all for being here, and thank you, Louis, for that extremely kind introduction. So I'll just quickly talk about, what's the outline of the talk. I'm just going to spend a brief few minutes talking about the problem motivation, and then just the challenge of, identifying actionable medical advice on social media platforms. That's kind of the motivation, and I'll talk about this paper, what we try to do. So, what's the motivation for this talk? There are increasingly a lot of discussions in the area of healthcare about how to get more adherence from patients. So things like chronic conditions, diabetes affects millions of people, and they're some of the biggest contributors to healthcare costs and healthcare spending. So, the idea that's very influential in, I think, healthcare economics as well as the practitioners, the healthcare practitioners, is that can we find some small interventions? Maybe you can call it nudges or what have you. But can we do things that can make people take proactive steps to increase their health? So, for example, there was, this was what motivated us. There's like this program in England where, the doctors would prescribe a little amount of physical exercise. And, that turned out to be wonderful from perspective of chronic diseases. People's, the self-empowerment with which patients can, do things proactively led to enormous increases in well-being, increases also the patient and physician interaction. Overall, it's great from a macroeconomic perspective. So that was what motivated us to look at social media, right? Social media is just, I think, 1 out of 10 searches on Google, actually 1 out of 7 searches on Google are healthcare related. And likewise, people go to YouTube, people go to all kinds of Twitter, social media to search information about healthcare. So is there something we can do to harness? One kind of initiative is the Google Trends, using Google Trends from prediction purposes, which many of you are already familiar with. But what motivated me after spending so many years studying social media is, can we find these little digital interventions that can use health technologies to help doctors? And can we automate this process, right? So what is the challenge and with doing something like this? Can I find YouTube videos and give it as a sort of digital prescription, deliver it to doctors so doctors can recommend watch these two videos along with discharge instructions. The problem with that is, flies in the face of how social media algorithms work. Let's say YouTube. If you're searching for something like a cure for diabetes, you'd guarantee that the top searches will be rife with misinformation, right? It's not helpful. They have biased opinions against doctors. There is malicious content out there. And there's a lot of, uh, things there. People are promoting their own content, which is like a commercial sort of. So there is algorithmic bias, there is misinformation, there is promotional activities by companies. So, in other words, we are maybe drowning in COVID related information, but if we want to use YouTube, find that actionable advice that the doctor can take and give it to a patient, right? That is like searching for a needle in a haystack. Right? So let me just step back a minute and say, why is it that I want to use healthcare information on YouTube? Well, the thing is, this is another example where I'm searching results for, let's say, something like insulin pen. There is also a lot of valuable content out there on YouTube, right? Because social media is so democratic. There is content that's created by doctors, there's content that's created by patients, there's content that's created by, let's say, nutritionists. So there is immense potential as well as peril in social media platforms, in that you can use it as a force for good, you can use it as a force for bad. And so, there are basically, if you're looking at simple measures like view count, there is a popularity bias, so we are more likely to encounter healthcare information. So, this is my second motivation thing that sort of motivated me to work on this problem. It's almost like if you are searching for information on any social media platform related to healthcare, if you know what you're looking for, and you say if you have diabetes and you're looking for some metformin, very specific forms of advice, then you're more likely to encounter reputed organizations creating the content that is created by reputed organizations. Whereas if you're just going and saying a low, let's say, low information query such as diabetes, you will get a lot of malicious content, right? So there's also a health literacy divide in the types of information that people can see when they go to social media platforms. So this is why a lot of actually doctors, healthcare organizations, the World Health Organization, in fact, recently said that along with a pandemic, we also have an infodemic. So there's a lot of pushback from the medical community saying, please do not even Google things, right? So there are studies like this. So this was actually one of the earliest studies, more than a decade old. They looked at claims made in YouTube videos about immunization. Some of you may already be familiar with how much anti-vax information that's out there on social media platforms, right? So if you're evaluating these claims by doctors, what ends up happening is, it's really sobering how much fake information is out there, right? So this is the motivation for my talk. Now, what prompted me to sort of study this? And I'm combining social science methods with, I would say, algorithmic data science approaches. And the reason is exactly something like the study, where, content analysis by, let's say, doctors, patient education experts, if we want people to look at videos and evaluate, you cannot do it at scale. You can do it for maybe 100 videos, you can do it for maybe 200 videos. But there are a corpus of 50,000 videos or 100,000 videos. How can we evaluate those claims at scale, right? And that's the challenge that a lot of social media platforms are running into, that there is simply too much content out there. And what are some good approaches where we can automate this kind of evaluation of the validity of medical information on these sites? So that was this is the questions that I sort of started with, right? There is significant heterogeneity in the quality of medical advice that's there on YouTube, right? How can I extract and measure this quality? And, what is the other challenge? Doing, at least when I started the study, doing some kind of randomized field, a randomized control trial was pretty difficult from a number of issues, which is, one is the problem of scale. Like, can I give two different videos, one from YouTube, one recommended by my method? That would have been the ideal approach. And I'm kind of working on some of those methods right now. But the first step is using publicly available YouTube data. Can I find some proxy for how users actually perceive this information? Fortunately, we do have metadata on videos, and that's what we call the engagement with the videos. So we can quantify the collective engagement. So these are the two questions. One is, can I find a scalable method that measures the quality of medical information that's available in YouTube videos? And the second is, can I find some proxy for how users on YouTube, when they're seeing this healthcare information, how do they engage? What are some good proxies? How do I do a causal evaluation? Right? So far, so good. So please feel free to interrupt and ask me questions. And I think that will make the talk sort of more interactive. So, here I have basically a lot of data that I've collected from YouTube videos. And first step is, how do I assemble a corpus of YouTube videos? We started, my co-authors and I, by going to a site called Daily Strength. It's a forum. The condition we focus on is diabetes. Why? Because it's a very popular popular in sense, a lot of people have it, unfortunately. And sometimes diabetes also has a lot of like occurrences. People who have diabetes may have some other conditions too. So it's very complex from medical perspective, and a lot of people have diabetes, or they are at risk for diabetes. They have, some folks also have pre-diabetes. So this is place where there are, YouTube really has hundreds and thousands of videos on diabetes. Some of them may be low information, but there is really value in an algorithmic approach to assess the quality of information provided on diabetes on YouTube, and if doctors can somehow use that information. So the Daily Strength, which is a patient site where people ask a lot of questions related to diabetes. I look at what are the top search queries. So these are the most commonly discussed things that people think about when they have diabetes. So I use that to create a master list of queries that people are likely to come up with on YouTube. So why would I do that? Because I want to sort of almost like simulate an environment where, if somebody has diabetes, or they think they have diabetes, or they know someone who have diabetes and they're searching for YouTube, what are the kind of things that people are looking for? And so I need a proxy for this search behavior. So once I have all those, that's the word cloud here, right? What do? Use YouTube data API, and we can get two kinds of information. We can get the metadata about the videos, which is title, description, the topic of the videos, like count, who is the content owner, is this a reputable organization? We also have some geo data, the geographic, but we didn't really use some of that. The other kind of information which we also did is, we could actually download the video itself, and we can run the video through Google Cloud API, and we can use some of those, like the transcription of the video, the words that are said in the video, the narrative, the frames, how coherent is the, so we can do a lot of video analytics too. But first, I'm going to talk only about this part, which is the metadata. So there is a lot of data that I can get about these videos, right? So what's my next challenge? And this was like our biggest stumbling, this was our most challenging thing that we encountered, is, how do I identify whether this video is a valid medical video or not valid medical video? And there is some precedent in the area of spam detection. right? And there's like, we have a lot of literature on fake news. But as it happens, evaluating the quality of medical information is more of a challenging problem than even fake news. Because fake news, oftentimes, we can look at who is the person posting, or we can look for some kind of hyperlinks between the fake news links. But here we don't have, that's not so easy to detect medical information. And it's also something like, what people say, how to lie with statistics. You can easily fake medical information by using a lot of medical terms that can throw off people too. So it's really two steps to how do I actually quantify whether this is valid medical information. The first step is what I'm going to talk about now, which is medical relation identification. In the natural language processing in computer science, there is what they call named entity recognition. That means you can recognize if something is a noun, if something is a place. So I'm using the named entity recognition methods to identify what I call medical entities. The second step is I refine that further using input from doctors. And then I can create a classifier, a logistic regression based classifier that takes a corpus of trained data, the data that has labels, and then I can predict which video is likely to have valid medical information, which video does not have valid medical information. Is this sounding okay so far? Any questions from the audience? I'm assuming no questions. So, what is a medical relation, the named entity recognition? There is the National Library of Medicine has this resource called UMLS, Unified Medical Language System. Right? What does medical language system do? It basically talks about any disease is something like a semantic relation between entities that can be disease or treatment or condition, and there's also relationship between those, like something treats something, something prevents something, something contraindicates something. I'm only addressing the first part of it, which is identifying the named entities. So, what essentially a method called bidirectional long short term memory, which is basically a recursive neural network. Right? So, the first step of it is what is called a word embedding. Word embedding is a way that we can take text data and we represent text data in a kind of a vector form, right? So basically any two diseases or any two collections of diseases, we can almost map the distance between those two vectors. This is a little bit like what people have also used this to study, let's say, fake reviews on Amazon. You can use the same kind of method where you take a piece of review text that would be called a document. One review is, uh, I'm sorry, one review, the text data from the review would be your document. And you can uh, do an embedding, which is basically produces a vector representation. And then you can compare. Yes,
so,
go ahead.
Anjana, so we have a question from Hannes.
Yes.
Yeah, so I hope I didn't miss this, but so how can you measure the quality of the information here? So
Yes.
if so on the previous slide, if we say that something treats something, what if it says homeopathic medicine treats cancer?
Yes, that's correct. So that's why I said my method has two parts. First part is just let's measure. What should I say? Are these two entities medical entities or not? So my first step, the bidirectional long short term memory, will only get you a list of words. Then second step, I have basically two stages of input from doctors. Right? In the second step, I have independent of my BILSTM method, I will ask doctors to watch the videos and rate them on, is this something valid? Is this something not valid?
Okay.
So that is how I can scale my method. You are probably wondering why we need both approaches. The reason is because I have such a huge corpus of data. So
So
at
you
least,
use the physician's expert opinion to label. Is that
yes,
okay? All right.
correct. That's
Okay.
exactly what I'm doing.
Okay.
And the problem is, before we get to the physicians labeling, we can't ask physicians to label 10,000 videos. That's why my BioLSTM serves as a kind of a screening mechanism, if you will.
Okay.
Sounds
Great.
good?
Thanks.
So
Yeah.
it requires 2 levels of labeling.
Okay.
Yes. And I'm not saying again that this is completely bias resistant method. I would be wary of making too many claims because of the immense complexity of this problem. But me and my co-authors, what we feel is at least we are making some progress in such a complicated, problem. Right. So that's exactly what we're doing. So I want to talk just briefly 2 things that we have to keep in mind when we are even trying to identify if there are medical terms in a video, right? There are what are called dictionary based approaches. For that, you need an immense dictionary of medical terms. And then we can do like almost like a check, right? Is this there in the dictionary? Then I can label this video as, I don't know, medical video, right? I'm just giving a rough idea. Here is the thing though. In my case, I'm not using a dictionary based approach. Why is that? Because the things that I'm trying to label or classify are videos, the metadata from videos, which is, this is consumer generated vocabulary of medical terms in social media. This is not how doctors are describing a disease. And actually, I will show you some evaluation results. So my method is the bidirectional LSTM, bi-LSTM method. It actually outperforms these dictionary-based approaches. We have to do some robustness checks to see how robust is our method, right? So that's actually one of the interesting things that the neural networks are better at teaching themselves things. And if there's some informality in how people talk about medical terms, because we are consumers and we are just talking about diabetes without using professional language, how can we teach the classifier to identify that better, right? So before I do, I will go back to the previous slide. So there are lexicon based approaches, which is dictionary based approach. The Some approaches in the field are what are called conditional random fields. I actually find significantly better that BioLSTM is doing better at teaching itself how consumers talk about medical terms on YouTube. And that's like, I think, one of the innovations of my approach, because this is a problem relating to social media and I can't use lexicon based approaches. So, what was one of the biggest challenges? We had to spend a lot of time refining our BioLSTM. One of the things we found is, identifying boundaries of terms. Like, I think sometimes there's wrong, not medically relevant profile, curbing, cushion, things like that. The false negatives were things like we were excluding a lot of acronyms, right? So I think the BioLSTM was, and what about, that another challenge you'll find is we are doing a word embedding. Word embedding is looking at relations between discrete words and not phrases. Sometimes yes, go
Sorry,
ahead.
Anjana, we have another question from the audience.
Yes.
From Jikan Jong. So maybe, I will unmute you so that you can ask your question. That's okay with you. Well, I don't.
Thank you for great presentation. How about your distribution of the labels? Because if it is imbalanced data, so if it's like positive is too much, like your 90% of your data is positive. If we just predict as a positive, in that case, its accuracy become 19%. So did you actually check whether your label distribution? Thank you.
Yes. We have to do, we followed all the standard computer science. Co-author on this paper has a lot of training in the computer science methods. So yes, we have to check all these distributional assumptions. And I think the paper itself has some of these details in a technical appendix. But I think in the public interest, at some point, we should just post all these additional details that people ask us on our websites or something like that. We have to do immense number of additional tests to make sure things are, in the correct form and we are specifying stuff correctly. But as exactly as I talked about, the challenge was actually twofold. One is you're trying to understand how consumers talk about medical terms. And the other is that we can easily misclassify boundaries of place, like something like plasma free fatty acid. That was, are we recognizing it as a medical term or not? So, just to give an example from a completely different context, right? If you're trying to use Twitter to predict maybe like asthma related emergency room visits, um, one of our colleagues ran into this problem that went to a Justin Bieber concert and they'd say breathless, or their hashtags like breathless. So that can easily confound your measures on Twitter. So we were running into some issues like that. They were not as don't sound as funny as the Justin Bieber example, but it's really, are we the carnitine synthesis of magnesium or alpha ketoglutarate? uh, are these medically relevant words can easily confound, what is a medical term, and we have to be very, very careful about that, right? So this is kind of my performance evaluation for the extraction of medical terminology, and these are some of the descriptive statistics. And maybe I can give a little bit more performance evaluation details. Basically, what we also had to do is, how well are these approaches performing at the body part level, at the chemical? Because remember, we're also talking about what drugs are prescribed and how people are adhering, right? And sometimes people have to use a device, like, for instance, a glucometer. People are using a glucometer to measure glucose levels. And there may be YouTube videos on how to use a glucometer. But just because the video says how to use glucometer, is this really providing medically accurate advice, right? And then there are events, there are people, procedures. So again, BioLSTM is significantly better, just because I think it's just better in recognizing or teaching itself the consumer, the sort of how informally people can talk about medical terms. But I think again, we just have to be very, very cognizant of, here are some pitfalls with this approach, and here it can significantly do better in terms of refining this method for future work. So this is kind of my empirical approach. I've extracted some medical terminology, and for a subset of videos to refine my analysis, I can also do some caption mining, because YouTube generates auto captioning for at least a subset of videos. Then I can also do some image mining as a robustness check. So extract the frames per the videos and look for, can I detect some medical objects? And will that somehow make it more credible? But again, we always run into this problem of, like, as I said, how to lie with statistics. You can easily have fake information and put a medical sounding thing or a stethoscope, and that can really confound your analysis, right? So that's why what we did was, once we extracted the medical terms, we just have like a normalized measure of number of medical terms that was used in this logistic regression, where my training data came from physicians actually viewing and saying, is this medically valid or is this not medically valid? Then what I can essentially do is, I can take this label, and the rest of the videos that are not labeled by the physicians, it becomes like a prediction exercise. You can predict which of this is likely to have medical information, which is not likely to have medical information. And then we can classify the unannotated data. And we also have a lot of metadata. We have likes, we have popularity, we have content engagement statistics. So content engagement in a lot of people who study social media is a good proxy for how users are sort of interacting with the medical, with the content itself on social media. So I did propensity score match, where basically we found 3 dimensions of content engagement. One is sort of non-engagement. People may come to a video and they'll just go away because they don't like it or something like that. The other measure was essentially measuring popularity based measures. The third measure was more of in depth, are people actually watching, they're coming back, that sort of stuff. And so I'll just quickly give you the end result right now. What we find when we do these collective engagement measures is, before I even go to the next step, which is we did propensity score matching, but the model free evidence just shows that the number of medical terms itself was, the more number of medical terms, significantly less popularity, right? The most popular videos on YouTube are the ones that have, very roughly don't have a lot of medical terms out there. So you search for diabetes, you find miracle cure of diabetes. Those are the videos that are significantly more likely to be watched. And, let's face it, we didn't do a control for the popularity bias in recommendations, but because recommendations on social media platforms are so also biased towards popular content, what also ends up happening is those are the videos which will get also recommended and so on. So, it's a significant, I'll just give you this model free evidence. If you're looking at the actual medical information on video, the probability, the engagement is kind of lower. It's almost like that, right? So here, let me now talk about my empirical approach. I have probability whether a video contains high medical information. Yes.
Yes, Anjana, we have another question by Hannes, who wants to follow up on his earlier question.
Sure.
All right. So I had to start on the previous slide. So you use the annotated data to train the model, and then you predict on annotated data. So did you also predict on a part of the annotated data which you didn't use to train to check out of sample
Yes.
prediction?
Yes, we
Okay.
have done a lot of those.
Okay.
Yeah. And in fact, this is another issue, right? One of the things we are kind of grappling, I think, right now is, if we have some sort of there are biases like racial bias or something, then one of the things we'll have to do in future is to have train the algorithm on a very popular condition, and then train it on maybe a condition that afflicts a subset of the population, and look for biases in training. And that's something that we haven't done in the study, but we really have to do a lot more. We have done obviously subsample analysis, and we have to leave conditions out. For example, I think one thing that we spent some time discussing is diabetes as it afflicts the general population versus something like diabetes mellitus, which is somewhat lesser popular. I mean, it's less frequent condition. I should not use the word popular. And there also are things like diabetes in children. So we had to do some of those checks as well.
Okay.
Yes, it's a great question. And this is one of those things where we really are still learning some parts of this problem, because there can be, how we recognize medical terms may be very sensitive to the context. And, and we are seeing that with COVID as well, right? And there are some lesser known complications. So if people are searching for those, what kind of results will people get? There are some things that are more frequent. So there are a lot of issues to consider as we are sort of proceeding with this problem. But thank you very much. Yeah, that is something we really have to worry a lot about. Any other? So we've done some propensity score match. And so, again, these are some, results. Basically on the three, we discover sort of three categories of user engagement: non-engagement, selective, attention-driven, and sustained. And obviously, as we say, users either are less likely to engage with the videos. So the videos that are complete junk, they don't get too many views as well. But the videos that are high quality videos also don't get too many videos. So there is almost like a U-shaped relationship between the level of medical information and the engagement with the video. So it's almost maybe a little bit of medical information, and then these are kind of popular or something like that. It's the inverse you, I should say, right? So too much medical terminology is kind of hurting engagement with videos. And we did a lot of robustness checks too, some image content analysis, video caption analysis. We had some expert evaluations too to refine some of our measures. So this is basically, some of our policy implications. What I think the advantage of methods like this are, we really are very much interested in our method should become the basis for clinicians to, this is something actionable that people can do, can use some algorithmic approach to at least find some videos, and then the doctors can use this in their practice, and that can become like a randomized control trial. We give these videos versus maybe you can give some randomized videos and then see the efficiency or follow up visits, what happens to patient engagement, or what happens to the patient and the doctor patient relationship. Would that qualitatively change if they had better information and so on, right? So it's one thing what we want to do is very much like a computer science method of automated retrieval of high quality user generated content, right, that enables different kinds of engagement. But hopefully healthcare organizations can also use these methods for some sort of guideline for how to engage with complex medical information. The CDC in the United States actually has something like a clear communication index, right? And that's like, if any health communication is being given to patients, can we do some actionable advice to make it sort of more clear? I think getting more deep into video analytics and understanding a little bit more on how consumers understand medical information will help us in formulating some of these policies for more social media and all these micro platforms where people are really engaging a lot with medical information. So I mean, again, you know um, I think after I started doing some of this work, I've kind of become like an op-ed writer, and I've written a bunch of like opinion pieces, some of these. It's just fun to do. It's like, I think like this is like my hobby, sort of my evening job, so to speak, not my regular like work as a researcher. But what I found working on social media and just these algorithmic approaches to evaluate medical information, that itself it's deeply sobering at one level. It makes me optimistic, but it also makes me very, very like sad about the stuff that's out there and the immense challenge that we face as a society or as researchers into even finding some actionable things that we can all do, like policy recommendations in terms of how to enable social media for the good. So it's almost out of time, but I think I have a little bit of time to talk about the follow-up study. Do I have a few minutes to talk about the follow-up study?
Yes, sure.
Yeah, great. So the next step, starting from this, once I understood that, there are these differences in engagement, the next question I think that came to our mind is, well, clearly patients are dealing, I mean, it is very challenging dealing with very complex medical information on YouTube. So can we break down this complexity into multiple parts? So there is the validity of medical information itself, but what are some ways I can assess algorithmically if the information provided in a video is understandable from a patient education perspective? So that was led me to, this is my follow-up paper. This paper is almost done. I think we should post it pretty soon on SSR. And what there are these standards in in the United States. There is the Agency for Healthcare Research and Quality, AHRQ, which proposed these standard called PMAT, Patient Education Materials Assessment. What this PMAT does is, they have a guideline for written materials as well as audio visual materials, but it is like video is understandable when any consumer, no matter what their educational background, can process and sort of, understand the key message, right? So, what I have done then is I've been able to developed an algorithm, my co authors and I, and this method is based on something called co training. What co training does is, much like the previous approach where I used the video data, I also used additional data, which is the videos itself. Let me put it through Google Cloud Vision and get a bunch of video caption, video annotation, video transition from topic to topic. And so a co-training is a method where I have two classifiers working together on two different views of the data. It's almost like partition the data into two different views, train the classifier on one view, and then train another in parallel. And I use human annotation, right? This is like, what would I say, augmented intelligence, human in the loop AI. When there is a problem in misclassifying, we can get a patient education expert or a doctor to view this video and decide, resolve the inconsistency. So, what has this method done? This method,
Anjana, we have
yes,
one more question from the floor.
sure,
So
sure.
it's from Anil Kumar. I can unmute you. Actually,
Madam, I'm calling from Mumbai. I wanted to know whether that previous study of yours that you took, you
Mhm.
told about infodemia. So
Yes,
whether there is in India a lot of cure is being talked about COVID
yes,
and lot of misinformation. So
yes,
can your study also be done in India? Like what you
yes, absolutely.
so
Yes. Actually,
okay.
one of the things I felt was, the in my approach, the things that are like we have a high medical information and no low medical information, and starting from the low medical information that can be used. I think it's like almost a two-step decision tree or something. We can refine that more into creating a kind of misinformation index, because misinformation is more insidious than even low information, right? It can be outright lies or pushing some sort of conspiracy theory or something where people are actively even resisting valid medical advice. So very much, yes, this can apply to other settings, countries like India, and so on. I think Facebook has some grants in this space, and a lot of people are working on these kinds of problems. And I would say that, WhatsApp has been especially pointed as a culprit in this, especially in the Indian context, in its ability to spread sort of misinformation, right? So I'll just briefly now close with, one of the big things in my work, what I've tried to do is every algorithm that we develop, we also need comparison with medical experts. So, I mean, that's like the most heartening thing for me is we are able to get precision measures where I can just run my algorithm on a corpus of videos. Then I can do like top 10 videos on YouTube. I can take some top 10 on each condition and run it through my algorithm and compare with how doctors would compare, would rate these videos, either in terms of understandability, either in terms of actionable medical advice, or either in terms of, is there valid information? But at a very preliminary level, I think our methods are able to do a very good job of recognizing whether information is valid or not valid and things like that. And that to me is the most heartening thing as a researcher. And I hope that more people will study social media, and especially the epidemic of misinformation on social media when it comes to healthcare. Is one of the biggest challenges of our time, especially in that we are all suffering from this COVID pandemic.
so
And so yes,
Hannes has another question.
sure.
So this might be slightly off topic, but seeing this plot, I mean, have you thought about whether YouTube, for example, could show your predictions on the side of the videos? Say this has a zero 0.7 expert score. Would this be an interesting experiment to?
Yes, but so far I mean, I haven't like really talked to anyone in YouTube, but yes, it would be a very. I think for future any experiment, it may be interesting to see. I think they have so far one thing that YouTube has done, right? It is showing whether this video, if it is valid, they will show links to CDC, and they will show like links to like Mayo Clinic, things like that. So I think that itself is an experimental condition. I don't need something like what I'm doing.
Hmm.
That itself can be treated as an experimental condition. And I haven't done those studies, but that itself is experimental. The reason why, again, someone like me, the reason for me for working on this method is that YouTube can only provide those links for only a very handful, very, very popular videos. I think at least right now, they don't have, or they're not interested, or they don't have the capability to provide this valid screen check for like each and every video that's out there.
Okay.
But they should. I mean, in my opinion, right?
Would
If
be
you
an
walk
interesting
in,
thing. Yeah. Yeah.
yeah, I think Sinan has said this, Sinan Aral, right? If you walk into a store, any food item, there's a FDA label, but you can go to YouTube and there is no label on the accuracy of content,
Yeah.
right?
And I think on TV, I mean, on linear TV, there's also media councils, right?
Yes,
Yeah.
yes, yes.
Right. But it's a bit off topic, but
No, but we have also wondered about, what are good ways to evaluate the acceptance of this healthcare advice, whether this would be a quality check. I mean, for my propensity score matching, that itself will, whether uh, uh, a video has a check next to it from like CDC, Mayo Clinic, that itself is a good treatment condition. But beyond that, in terms of randomization experiments, there is a lot to be done, that's for sure. More questions?
Madam, I'm doing some work in deep fakes. So can you
Uh-huh.
suggest some topic like we recently this BJP used deep fakes as a video and did something. It's
Mm-hmm.
happening in US also. So
Mm-hmm.
something on that.
Well, I think I'm a little bit out of my depth in commenting on deep fakes. Because my method so far, what it's doing is just measuring the number of medical terms and then getting some annotation, correct? The thing with deepfakes would require more methods like a GAN, a generative adversarial network. What I have is a recursive neural network, but it's called BiLSTM, right? I mentioned already. With GAN, I think you have essentially two classifiers that are, it's like an adversarial game. They're gaming each other. So we might need slightly different methods than what I have done in this paper, right? And again, I think deep fake is not necessarily like every fake. There are a lot of shallow fakes out there, right? And to me, shallow fakes can be even more problematic than deep fake because a shallow fake can be something which looks very plausible, whereas deep fake, looking at it, it's funny, but we know that, you know, for example, 1 year back, somebody posted a deep fake of Mark
Obama.
Zuckerberg, Obama, and also Mark
Yes.
Zuckerberg.
Yes. Yes.
Yeah. So those were, we clearly know the intent of the person. So we will laugh at it, but we won't take it seriously, right? So again, these are more of adversarial learning. There's reinforcement learning. There's a lot of methods in computer science. But the issue is for social scientists, I think to use some of those methods in studying these in the appropriate manner, like economists would do randomized control trials, causal inference. So we have to appropriately combine those two methods to get at I think, the right solution. And that to me is the challenge.
Thank you, madam.
More questions?
Nope. So Anjana, are you done with your slides or are
Yeah.
you? Yeah, okay,
Yeah.
okay.
Yeah.
So if there's no questions, I kind of have one. I was just wondering on your first paper, your measure of engagement and this kind of U-shaped relationship you mentioned.
Mm-hmm.
So how should I interpret the engagement measure? Is it like how much a person, how long do they watch a video, or how much likes, or do they keep watching other videos?
Yes. So that's why we did this principal component analysis, right? So the principal component analysis found three dimensions of engagement. That's why when I said, U shape, it's kind of, I think I'm being somewhat imprecise, right? There is disengagement, which is people just go to video and it's like a high bounce rate from the video, right? That was what the metadata showed. Then there is selective attention driven engagement and the sustained attention driven. The second dimension was really something which was measuring, just popularity, likes, views, just counts, right? And then we are looking at more in depth. Did someone go back to watch it? Did they actually engage with the video? Did they write comments? So that's the finding to us is very high medical information. First is, there is also the disengagement is kind of lower. So on the one hand, if there is a lot of medical terminology, people might just go away from the video. And moderate levels of, I think the moderate levels of medical information in a video were leading to more of, there was popularity, like sort of up to a level, right? And again, high levels of medical information in a video, we are seeing the sustained attention is very good. So that's like the both good and bad when we talk about how people are engaging with health information. On the one hand, there seem to be these very engaged people who go to YouTube and they go to CDC and they watch all the actionable advice and they go to the Mayo Clinic and they are like, tell me, Dr. YouTube, tell me what to do. And looks like they are listening, right? But there's also the people who are going and watching, all these rumors, conspiracies, and COVID is just not like anything worse than flu or what have you. So I'm essentially finding both patterns for both those patterns of engagement from my analysis of YouTube videos. Does that answer your question?
Yeah, so I guess I was wondering like what was driving those things. So for instance, if I look for specific symptoms that I have or something, and I come across a video that I think is very reliable, and the news are bad, or I interpret them as being bad, I may just, go to my doctor right away and just forget about YouTube. And if I'm not convinced, then because maybe I think the source is not as good, then I may keep searching a little bit more. So I just was wondering what's driving this extra
Yes.
engagement.
Yes, and it's absolutely great question. Something that, as we said, the first step, what motivated us is, let's even establish, can we even establish some kind of baseline of how valid is the medical information on YouTube in a large scale study, right? Because most of the literature, people have studied it in the area of healthcare, but they're all like small sample, 150, some 150 videos that a few doctors would have watched and, sort of given their opinion, right? So this is the first, to our knowledge, first very large scale study where we are measuring even the quality of medical information. There is like nothing before. So that was part of our challenge. And you are absolutely correct about this, right? What are, you know, on the one hand, you have high literacy consumers, they can be low literacy consumers. They are people who are maybe watching YouTube and that may be discouraging them from going to the doctor. The other set of people are confused by YouTube and say, I will never go to social media ever again. And let me just go talk to my doctor right away. So empirically, how can I distinguish between all these things? I have to acknowledge that it is hard to distinguish, right? And one of the things that occur to us as a result, as a likely explanation for the causal mechanism, is that maybe the highly engaged users are high health literacy consumers, and low engaged users are the low health literacy, and that would explain this discrepancy. But moving on to quantifying these different kinds of engagements and linking it to health information seeking behaviors online, that itself is another huge problem. And one where I think we are trying to partner with some health clinics and doctors, but we will need more input from medical clinics to do some longitudinal before and after, to even we need some kind of way to classify people along the dimensions of what kind of health information consumer are you, right? And so that would answer your question.
Yeah, thank you. So there's another question by Jikan again. So I think I unmute you.
Thank you for great presentation. I have several questions. How about the changing the dependent variable like, dislike, sharing
Mhm.
or not sharing? Because
Yes.
if we can predict what type of the video
Mhm.
the people like, we
Yes.
can actually design something more like
Yes.
some video people like a social
Yes.
distance. And
Yes.
second question is, could you distinguish like times and geological effect, like a
Yes.
certain type and then could you make it as some content, medical content, maybe fake or very low quality? Can you
Yes.
detect? The last one is, how about just apply lime or sharp? You can actually interpret your result after the prediction with some tools. Thank you.
Yes. Thank you for all these great questions. We've addressed some of those issues. That's why we wanted to keep it as a cross sectional study, because, over a period of time, there is the treatment itself can, the dynamic propensity score match type of thing. The the treatment condition in something like high quality, will this channel post good quality video or not? The treatment and the confound are not, it's not easy to isolate the effect. So the treatment condition will affect everybody. Sometimes that is the challenge. And there are methods that I've used it in some of my new the ongoing papers, but there's deep craft reinterpretation learning methods that can find like almost like a artificial, right, a counterfactual you can construct. It's a little bit like synthetic control methods, but it can work differently in a deep learning context. So those methods can address the first part of your question. I think your question had 4 or 5 points. I can't address all of them. Um, but we can look for systematic differences according to time trend, or is there some difference when the video posted date and so on. One of the interesting things that happens in YouTube is the half life of a video is not too high. Most videos, even the popular ones, they get half of their views within, like, I don't know, a month or something, very small amount of time. So cross sectional data collection is not going to change. I'm not sort of identifying which videos are going to go viral or not. That's not going to change my question. So it doesn't change the results that much. But we had to do several cuts of the data for our leave one out or some videos out kind of cross validation. And we had to deal with some of those issues that you mentioned. But those are all questions we have to consider very seriously. I think I'm sort of right on time. It's
Yes.
11:59.
Uh-huh. Yes, that's great. So we don't have any further questions. So I think Christian would like to say a few words. So you're muted.
Sorry about that. Thanks, Louis. Thanks, Anjana, for this very interesting talk. I just wanted to make a quick announcement for the next White seminar, which will be in 2 weeks on October 8th, same time, same place. We continue our list of stellar speakers and look forward to having Joshua Gans from the University of Toronto with us. You'll find the full schedule for the fall on digitalecon.org. Looking forward to seeing all of you back in 2 weeks. Thanks again, Anjana.
Thank you so much. Thank you.
Thank you.
Thank you all.